Charles L. White III, MD, is a professor of pathology and holds the Nancy R. McCune Distinguished Chair in Alzheimer's Disease Research at the University of Texas Southwestern Medical School in Dallas. Dr. White earned his medical degree at the University of Arizona College of Medicine. He completed 5 years of residency and fellowship training in anatomic pathology and neuropathology at Johns Hopkins. He took his first faculty position as director of neuropathology at UT Southwestern in 1983 and has remained on the faculty there for 40 years. Dr. White's clinical and research interests focus on neurodegenerative brain disorders. He has been generously funded by the NIH, the Michael J. Fox Foundation, the Chan Zuckerberg Neurodegeneration Challenge Network, and the Texas Alzheimer's Research and Care Consortium, and has published over 200 peer-reviewed papers. Dr. White is also the program director of the ACGME accredited neuropathology fellowship at UT Southwestern, which has proudly graduated 27 trainees to date. Dr. White has been active in the AANP since 1982. He served as its president from 2012 to 2013 and is currently the AANP archivist and senior associate editor of the Journal of Neuropathology and Experimental Neurology. He is most grateful to have received AANP's award for meritorious contributions to neuropathology in 2020. Please go ahead and share your slides, Dr. White.
Thank you, Angelica. I assume everyone can see and hear okay?
Yes, perfect.
Thanks to the organizing committee for inviting me to give this presentation today, and thank you to everyone out there in cyberspace for attending. My topic for today is tauopathies. I have no relevant financial disclosures to make. By the end of the session today, you should be able to discuss the normal structure of tau and the alterations that occur in tauopathies, explain the role of IHC in distinguishing between the various tauopathies, list the neuropathologic features that distinguish primary age-related tauopathy from Alzheimer's disease, and list the unique diagnostic lesions that characterize each of the major subtypes of FTLD tau. Tauopathies, to begin with, can be defined as disorders that are characterized by the presence of aggregates of abnormal tau that are deposited in the CNS neurons, glia, or both, and are associated with neurodegeneration. They may manifest with progressive but variable components of clinical signs and symptoms that primarily include cognitive impairment or movement disorder, especially Parkinsonism, or in some cases both. Noteworthy is that clinical deficits are not required for a diagnosis of tauopathy. So as neuropathologists, we can make a diagnosis of tauopathy without involvement of any clinical colleagues. The basic features of tau protein are important to understand so that we get an idea of the basis of these disorders. Tau protein is classified as a microtubule-associated protein, its main function being to facilitate the assembly and stabilization of primarily the axonal cytoskeleton of neurons through its interaction with tubulin, and these interactions are regulated by the phosphorylation of the tau molecule. Tau is encoded on human chromosome 17, the so-called MAPT or MAPTau gene. And from this gene, we get 6 isoforms of tau that are result from the alternative splicing of a precursor messenger RNA, alternative splicing involving exons 2, 3, and 10 of the 16 tau exons. Here's a diagrammatic representation of the tau molecule and its 6 different isoforms. Note that near the amino terminus, there are either 0, 1, or 2 amino terminus inserts that are encoded by exons 2 and 3. In the microtubule binding domain, there are either 3 or 4 what are referred to as tandem repeats in the portion that binds the tau molecule to microtubules. Most noteworthy is the second of the 4 repeats, which is encoded by exon 10 and illustrated here as the yellow box. And so if you have 3 repeats in the microtubule binding domain, we would call that 3 repeat tau. And if there are 4 repeats, including the exon 10 transcript, we refer to that as 4 repeat tau. So you can see that there are 3 repeat tau isoforms and 4 repeat tau isoforms. In normal brain, the 3 and 4 repeat tau is present in approximately equal proportions. There are a variety of ways that we can classify the tauopathies. Certainly we can classify them clinically, but because there's significant overlap and non-specificity in the clinical presentations of most of the tauopathies, that's not a terribly useful classification. Another way that tauopathies can be classified is by either there being primary or secondary. This is a little bit arbitrary, actually. The primary tauopathies may be genetic or sporadic, and they're usually restricted to 3R or 4R only lesions. Secondary tauopathies, like primary, may be either genetic or sporadic. Examples include Alzheimer's disease, which is classified as a secondary tauopathy because the presumption is that the underlying pathogenesis of the disorder involves A beta toxicity that results secondarily in tauopathic neurodegeneration. Another example of a secondary tauopathy is the ALS Parkinson disease complex on Guam, which is considered a toxic or environmental disorder secondary to the ingestion of toxic moieties from the cycad plant. And CTE, or chronic traumatic encephalopathy, being ascribed to repetitive bouts of head trauma, is also considered a secondary, aka environmental tauopathy. You can classify the tauopathies based on genetics, but this also is a little bit problematic because, for one thing, most tauopathies are in fact sporadic. The mutations in tau that result in tauopathies occur in the tau gene on chromosome 17 and have been classically referred to as FTDP17, meaning frontotemporal dementia with Parkinsonism linked to chromosome 17. These can be exonic or intronic mutations. They're mostly missense or deletion mutations. Again, most genetic forms of tau mimic the neuropathology of sporadic forms, so genetic classification isn't terribly useful. It's probably better to classify based on the neuropathology and then specify whether a given case is sporadic or genetic in etiology. So for our purposes, really the best way to classify the tauopathies is based on their neuropathology. And this includes lesion morphology, the type of cells that are involved, the distribution of lesions, and the type of tau isoforms that are expressed. And conveniently, we can identify tauopathic lesions by using antibodies to phosphotau and also antibodies to the 3R and 4R isoforms of the molecule. Currently, cryo-electron microscopy has begun to reveal disease-specific conformational folds in tau filaments that seem to be unique for given disorders. Again, not something that's extremely useful in day-to-day practice yet. There are a lot of post-translational modifications that can occur on the tau molecule. Most importantly, phosphorylation, which can, again, not only be important in the modulation of tau and its physiological functions, but also can be present in aberrant or excessive amounts in most of the tauopathies. And we can use antibodies to phosphotau to identify the lesions in the tauopathies. Similarly, antibodies to the tau isoforms can be used to identify the post-translational modifications that result in abnormal ratios of the 3R and 4R tau isoforms in some conditions. Now, there are something like 25 different tauopathies, so rather than spending the entire day on the topic, I picked out a handful of illustrative disorders that will kind of give you a sense of the major tauopathies and give you a framework on which to be able to think about these disorders. So first, we'll cover Alzheimer's disease and Alzheimer's disease-like disorders, including primary age-related tauopathy. Then I will cover three of the major FTLD conditions that are associated with tauopathic lesions, the so-called FTLD taus. And then finally, I'll discuss one glial tauopathy, globular glial tauopathy, that's important in causing clinical disease. So first, let's jump into Alzheimer's disease and AD-like disorders. Alzheimer's disease was first described as a clinical pathologic entity over 100 years ago by Alois Alzheimer, who described, quotes, a characteristic disease of the cerebral cortex in a patient that had been followed for several years with a progressive cognitive disorder. Illustrated here are Bielschowski stains like Alzheimer would have used, illustrating neurofibrillary tangles in the panel on the left, and illustrating a neuritic senile plaque on the right with the black staining silver positive tau aggregates in the neurites around the periphery of a central amyloid core. Alzheimer's disease itself is defined as a clinical pathologic entity that's characterized not only by the neuropathologic lesions I just showed, but also by dementia, meaning a generalized deterioration in multiple cognitive domains that may include language, memory, concentration, visuospatial orientation, and executive function among the key elements. So, and since Alzheimer's first description of this clinical pathologic entity, we labored for more than 100 years considering Alzheimer's disease a clinical pathologic entity that required the presence of dementia. The Khatchaturian criteria in 1985 and later the CIRAD criteria published in 1991 both relied on senile plaque density as the important neuropathologic component required for a diagnosis of Alzheimer's disease. The 1997 NAA Reagan Institute criteria required both senile plaques and neurofibrillary tangles. This followed in along on the 1991 publication by Brock and Brock of the stereotypical hierarchical accumulation of neurofibrillary pathology in aging and Alzheimer's disease. Noteworthy, again, is that all of these above criteria were applied to determine, quotes, the likelihood that dementia was due to AD lesions. So again, these all applied to patients who had cognitive impairment. Now, as the years went on and we did additional studies of not only dementia, but aging subjects, it was quickly realized that you could develop the lesions of Alzheimer's disease in the absence of significant clinical disability. So in 2012, the criteria that were published under the rubric of the NIA Alzheimer's Association criteria distinguished plaques and tangles and dystrophic neurites, or what we call now Alzheimer's disease neuropathologic change, from the clinical pathologic term AD. And it was noted that such changes may be present in subjects with normal cognition, which we often refer to as preclinical AD. In mild cognitive impairment, that is usually just an affectation of limited cognitive modalities, most commonly memory, or full-blown dementia with the multi-domain cognitive impairment characteristic of full-blown Alzheimer's disease. So, I started out talking about Alzheimer's disease as a clinical pathologic entity, and I gave you the clinical features first. From this point forward in this talk, I'm going to discuss the neuropathology of the various tauopathies and only give you the clinical features that are common for that particular entity at the end to de-emphasize the importance of the clinical features for making the diagnosis of these entities. Now, 1 year ago, Eddie Lee gave a really nice talk on the diagnosis of Alzheimer's disease and its associated comorbidities. So I'm not going to go into detail repeating what he said. I would refer you back to the recorded version of his session if you want a refresher on this. But I will just illustrate quickly these two tables from the 2012 article that point out that for a diagnosis of Alzheimer's disease neuropathologic change, we score the Thal phase of A beta deposition. The B score is the Brock stage of neurofibrillary tangle formation. And the C score is the density of neuritic plaques according to the previously published CIRAD eidetics for plaque density on a semi-quantitative basis. And then you jump down to table 3, and this is where you plug in the ABC score to decide whether a given case has none, low, intermediate, or high levels of Alzheimer's disease neuropathologic change. Importantly, Alzheimer's disease is characterized by the deposition of both 3R and 4R tau isoforms in the neurofibrillary tangles, dystrophic neurites, and plaque neurites that characterize the disorder, and 3R and 4R tau isoforms are present in roughly equal amounts. So Alzheimer's disease is a good springboard for discussing the next entity that I want to bring your attention to, and that is so-called primary age-related tauopathy. Now, the history of the way this entity developed was really based on the problematic situation created by Alzheimer's disease being a clinical pathologic entity, because many neuropathologists were beginning to discover that they would go to CPC conferences with their clinical colleagues who would present a patient who had a clinical diagnosis of cognitive impairment or dementia. And then the neuropathologist would present a case that had Alzheimer neurofibrillary tangles confined to the medial temporal lobes, but in the absence of neuritic plaques. And we would have to say, gee, this patient has some kind of cognitive impairment. We find no other explanation for it, no Lewy bodies, no frontotemporal dementia. But it doesn't meet criteria for Alzheimer's disease, and we don't really have a good term for that. So back in about 2014, following up on the 2012 criteria for ADNC that did not require a diagnosis of dementia, a couple of neuropathologists, John Crary and Peter Nelson, assembled a group called the PART Working Group that developed this term called primary age-related tauopathy, and pointed out that this was a very common finding in the brains of the oldest old subjects. And the diagnostic criteria for PART were established as neurofibrillary tangles with no or very little amyloid deposition or neuritic plaque formation. The tau isoforms, like in ADNC, were both 3R and 4R tau, and again, roughly equal proportions. The lesion distribution was typically restricted to the medial temporal lobes, entorhinal cortex, and hippocampus, rarely exceeding Brock stage 4, so not really extending out into the neocortex. Subsequent to that, another finding published in 2021 by Jamie Walker, Tim Richardson, and John Crary, is that in contrast to ADNC, which when it involves the hippocampus proper tends to affect the CA1 region of the pyramidal layer early, in part, there was often a finding that the CA2 area, illustrated here in these 3 cases, was primarily involved early on in part. So not only is it not an amyloid-driven neuropathology, but it's a neuropathology that has a slightly different distribution in its early stages from ADNC. Another characteristic feature, although not one of the key diagnostic criteria for PART, is that it's often characterized by the presence of large numbers of ghost tangles, extracellular tangles that are left behind as tombstones after the neuron in which they were previously resided has died. And these are common in the entorhinal cortex as well as in CA1 of the hippocampus. Curiously, they tend to stain predominantly for 3R tau without significant 4R staining. This is probably just a loss of immunoreactivity and doesn't really mean anything about the underlying pathophysiologic sequences that lead to the deposition of tangles in PART. The clinical features of PART include its occurrence in mostly the oldest old of the population, people age 80 and above. It is not associated with an overrepresentation of the ApoE epsilon 4 allele like Alzheimer's disease neuropathologic changes. It may be associated with a range of clinical cognitive function, including normal cognition, amnestic MCI, or full-blown dementia. Importantly, the extent of clinical disability tends to correlate with the degree of tau pathology. Okay, let's jump into the FTLD taus, or the frontotemporal lobar degenerations of tau type. Pick disease is certainly the oldest recognized form of this entity, and in fact, the oldest recognized form of FTLD. Of note, the original description of Pick disease ascribed to Arnold Pick was the combination of clinical and gross features, namely association of frontotemporal dementia features and language disability in the presence of what we now refer to generically as lobar atrophy. And it's illustrated here in this case of Pick disease in the lateral view by these really narrow gyri and widened sulci in the frontotemporal regions, and also emphasized on this medial surface of the brain, illustrating the predominant frontal and inferior temporal atrophy. This is often referred to as knife edge gyri because of the extreme atrophy of the gyral folds. Interestingly, the first histopathologic description of Pick disease is ascribed to Alzheimer himself in 2011, and Alzheimer used the same silver stain that was used to identify the tangles and plaques of Alzheimer's disease to identify these ovoid accumulations within the dentate gyrus of the hippocampus, as well as in the pyramidal layer of the hippocampus and in the adjacent temporal lobe. And these he termed Pick bodies. The neuropathologic subtypes of lobar atrophy envisioned by Constantinidis in 1974 were a result of the fact that neuropathologists began looking at a lot of cases of lobar atrophy with these language and cognitive deficits, and recognized that a significant number of them actually lacked Pick bodies. And so Constantinidis described three subtypes of lobar atrophy that he called subtypes of Pick disease. Pick type A was the classic kind of Pick disease, where we had the ovoid Pick bodies described by Alzheimer. Pick type B was cases with only ballooned neurons in the neocortex and no other recognized pathology. These we refer to mostly as cases of CBD in today's terminology, and I'll discuss that momentarily. And then there was type C, which was characterized by extreme gliosis and spongiosis in the neocortex, restricted mostly to the frontotemporal regions. And these probably represent now most other subtypes of FTD, such as those that are associated with TDP-43 proteinopathy. So this type ABC of Pick disease is not considered terribly useful in today's terminology, now that we have better ways of characterizing these entities by immunohistochemical techniques. Pollock et al. In 1986 were the first to demonstrate that PIC bodies contain tau protein, and Sargent et al. In 1997 demonstrated that PIC tau consists only of the 3R isoform. So the current diagnostic criteria for PIC disease include 3R tau immunoreactive PIC bodies in the dentate gyrus of the hippocampus and in the adjacent pyramidal layer and adjacent temporal and frontal areas. Here you see a low power view of an immunostained section of hippocampus from a case of PIC disease. You can see that the dentate gyrus stands out darkly because of all of the inclusions within the dentate gyrus neurons. And you can also see some immunoreactivity at low power out in the pyramidal layer, and then at high power, here illustrated in the dentate gyrus are the ovoid PIC bodies, very similar to those demonstrated by Bielszowski stain, but in this case demonstrated by 3R restricted tau immunoreactivity. Interestingly, PIC disease is so far the only pattern of tauopathy that seems to be restricted to 3R tau. Clinical features of PIC disease include mostly behavioral variant of FTD. They can be associated with progressive language disorder, and they can also be associated with something I'm going to discuss under the heading of the next disorder, which is a cortical basal syndrome. So let's jump into cortical basal degeneration. Cortical basal degeneration was first described in 1967 by Rebisch et al. And he termed this corticodentatonigral degeneration with neuronal achromasia. Neuronal achromasia being referring to large neurons with dispersed missile substance distributed throughout the neocortex. The first standardized neuropathologic criteria were published in 2002 by Dennis Dixon et al. Under the topic, the Office of Rare Diseases Neuropathologic Criteria for Cortical Basal Degeneration. I've often wondered what the Office of Rare Diseases looks like. I envision it as maybe like a janitor's closet or a broom closet back in some corner of the NIH. Cortical basal degeneration, neuropathologic diagnostic criteria include neuronal inclusions in cortical and subcortical gray matter, astrocytic plaques in the cortex and in the basal ganglia, threads and coiled bodies in the white and gray matter, and the presence of these ballooned neurons that were referred to as neuronal achromasia by Rebisch et al. CBD, in contrast to PIC disease, is characterized by the accumulation of 4R isoforms of tau only. This is a rather representative example of a low-power view of a case of cortical basal degeneration. These cases have typically tremendous deposits of tau throughout the gray and white matter, such that in many instances it's difficult to tell where the gray matter ends and the white matter begins. If we look at higher power at the cerebral cortex in this large image on the left, we see these accumulations of 3R tau immunoreactive processes that are reminiscent of the senile plaques of Alzheimer's disease, but these are, when double labeled for GFAP, actually in the processes of the glial cells, probably astrocytes. So these are the glial plaques that are characteristic of cortical basal degeneration. You also see that there are a lot of threads in the background, probably also mostly derived from glial cells, maybe some neuronal component as well. In the hippocampus, in the dentate gyrus, it's not uncommon to find these ring-like inclusions around the nucleus of the dentate gyrus neurons. And in the basal ganglia, we see not only a neurofibrillary tangle here illustrated as this dark staining cell, but also this lighter staining cell with kind of dot-like granular immunoreactivity for 3R tau in the cytoplasm. This we refer to as a pretangle. Here's a high power view of the white matter in a case of cortical basal degeneration, demonstrating again these threads throughout the white matter, but also in some cases C-shaped or circular inclusions encircling the nuclei of oligodendroglial cells. And these are the features that we refer to as coiled bodies. In the neocortex of the cases of cortical basal degeneration, we see these large pink neurons with the nucleus pushed off to the side and dispersed Nissl substance. These are the so-called balloon cells or achromatic neurons that are described in cortical basal degeneration. These can be identified to advantage with an antibody to alpha B crystalline. Alpha B crystalline is a normally occurring protein in glia, and also it's the most abundant structural protein in the lens of the eye. It often is expressed in neurons as a heat shock protein. So again, alpha B crystalline immunohistochemistry can be used to identify the characteristic ballooned neurons of cortical basal degeneration. Clinical features of cortical basal degeneration most commonly include the cortical basal syndrome, which I mentioned can also be seen in Pick disease. This is an atypical type of Parkinsonism that's characterized by unilateral or asymmetric involuntary movements that include rigidity, tremor, dystonia, and myoclonus. There can be motor apraxias, cortical sensory deficits, and even a curious phenomenon called the alien limb phenomenon as part of the cortical basal syndrome. The cognitive features associated with CBS are typically of the FTD type and include behavior and language abnormalities. Importantly, the cortical basal syndrome is not specific for cortical basal degeneration, the neuropathologic entity, because it can be seen with other pathologies. Strikingly, that includes Alzheimer's disease neuropathology, sometimes underlays the clinical expression of cortical basal syndrome. As I mentioned, Pick disease, also the next entity we'll discuss, progressive supranuclear palsy, and even CJD can present with the clinical features of cortical basal syndrome. Progressive supranuclear palsy is similar to cortical basal degeneration in the sense that it's a 4-hour restricted tauopathy, and it's also often presents as an atypical Parkinsonian syndrome. It was first described again as a clinical pathologic entity by Richardson, Steele, and Olszewski in 1963. The first neuropathologic criteria were described in 1994 under a group that was convened by the NINDS and headed by Ha et al. This set of criteria was a bit complex in that it included the characterization of neurofibrillary tangles in 13 neuroanatomic areas. It was based predominantly on silver staining methods. It had only moderate inter-rater reliability, and importantly, it did not take into account all of the currently recognized lesions that we know as being part of PSP in today's parlance. And those things include neurofibrillary tangles as depicted on the left, pretangles in the center, again, this kind of dot-like granular tau immunoreactivity, not in the form of a neurofibrillary tangle. And then finally on the right, an important astrocytic lesion in PSP is the so-called tufted astrocyte. Again, these are all 4-hour restricted tau forms that are easily recognized by immunohistochemistry. So in 2022, the Rainwater Charitable Foundation funded an effort to develop revised neuropathologic criteria that were, number one, simplified, number two, had higher inter-rater reliability, and number three, took into account the immunohistochemistry of PSP, including the important tufted astrocytes that form part of the neuropathology of this disorder. The PSP criteria really rely on sections that are typically gathered for the investigation of other neurodegenerative disorders, such as those promulgated in the 2012 criteria for Alzheimer's disease and related neuropathologic entities. Neurofibrillary tangles demonstrated typically by AT8 or 4R tau immunohistochemistry should be present in 2 of 3 areas, those being the globus pallidus, the subthalamic nucleus, and the substantia nigra, and there should be tufted astrocytes in 1 of 2 areas, including the perirolandic sensory motor cortex or the putamen. Clinical features of PSP, again, like CBD, it's regarded as a Parkinsonian movement disorder, but it's somewhat atypical in that there's severe postural instability with higher frequency of falls than associated with typical Lewy body Parkinsonism. There is an eye movement disorder called supranuclear ophthalmoplegia, which is usually characterized by paralysis of upward gaze. PSP tends to be refractory to anti-Parkinsonian medications, and it often presents as an FTD clinical syndrome with or without Parkinsonism. Finally, let's move on to one example of a glial tauopathy, and that is so-called globular glial tauopathy. Globular glial tauopathy, or GGT, was first described by Molina et al. In 1998 in a temporal lobe biopsy from a patient with primary progressive aphasia. And Molina et al. Described glial inclusions that were immunoreactive for phospho-tau and had a globular morphology. In 2001, Eileen Biggio et al. Described detailed findings from an autopsy case of a patient with an atypical FTD presentation and glial inclusions that had a globular morphology, and they were composed only of 4R tau. At the time, the term globular glial tauopathy had not been developed, and she referred to this as sporadic multisystem tauopathy because it lacked a family history, but was similar to some of the pathologies described under the heading of FTDP-17. Currently, the diagnostic criteria, as revised and codified in 2013 by Ahmed et al., include globular cytoplasmic inclusions in oligodendroglia and astrocytes, coiled bodies in oligodendroglia in gray and white matter, and restricted to the 4R isoform of tau. Here's a low power view of what is really one of these kind of postage stamp diagnoses. Once you see this, it's hard to mistake it for anything else. Again, these very large inclusions in oligodendroglia composed of exclusively 4R tau. There are also globular inclusions in astrocytes in GGT. Here on the left is kind of a large astrocyte containing some more clumpy tau accumulations than is characterized by the tufted astrocytes of PSP. So these are distinctly different from tufted astrocytes. And then oligodendroglial cell containing coiled bodies on the right. Again, coiled bodies can either be C-shaped or rounded structures that include, that encircle the nuclei of oligodendroglial cells. The typical features of GGT from the clinical side may take the form of frontotemporal dementia or motor neuron disease-like features, including extrapyramidal signs as well, or they can present with both frontotemporal and motor neuron disease type clinical features. So I just wanted to pass on a couple of technical tips. First of all, I think it's best practice to cut in a standard and comprehensive set of blocks initially on all neurodegenerative cases. First of all, to standardize the workup, to maximize the opportunity for demonstrating unexpected and even comorbid pathology, and also to avoid the need to do that detestable thing for neuropathologists, which is having to go back to the bucket for more tissue. Another thing I want to point out is that thioflavin stain, which is very good for diagnosing Alzheimer's disease and part, in one way, because it demonstrates not only the neurofibrillary pathology, but also the beta amyloid pathology of AD and its absence in part. However, thioflavin is not sufficient to demonstrate 3R and 4R restricted tau lesions. It seems to only demonstrate tau pathology when both 3R and 4R isoforms are present. So it's not sufficient for most of these entities. Therefore, it is worthwhile to have at least available an antibody to phospho-tau, and there are many suitable examples of those. And then finally, for those who make it a practice to immunostain for selective 3R and 4R isoform tauopathic pathology, are going to be aware of the fact that with the RD3 3R tau antibody, there's often a diffuse background staining in the neuropil that can interfere with interpretation of the immunohistochemistry for the 3R lesions. And there's a nice paper that was published in 2011 by Uchihara et al. Using a pretreatment with potassium permanganate and oxalic acid that virtually completely knocks out that background staining and can be really useful in increasing their signal to noise ratio when looking for 3R tau. Okay, at this point, I am supposed to take you to a virtual slide. So I'm going to stop sharing this, and I'm going to reshare the path presenter. He says, maybe. Okay, here we go. This is the virtual slide that I included for you all. And I'm happy for anyone to shout out what they think that the diagnosis might be if you've had a chance to look at this. I could call on you if we were present in the same room. Okay, I'm going to tell you what this case is. And this is a great example of a globular glial tauopathy. And I include this here because you're likely to see cases of CBD, PSP, part, and Alzheimer's disease, and even maybe Pick's disease in a regular neurodegenerative disease practice. But this one is pretty rare. I think that I've seen a total of 3 cases of this in 40 years. 2 of those recognized by one of my former fellows, Pat Malafronte. And this is a great example of a GGT. And it shows at low power, of course, there's lots of tau deposition in the white matter, which is replete with oligodendroglia. And if we look at high power, again, we see these very characteristic large globular inclusions that typify the oligodendral inclusions of GGT. Here's a nice coiled body here in the center. I don't have a laser pointer with the path presenter, but there are several other good examples of coiled bodies here. And if you look around, you can see some cells that are a little bit more astrocytic in morphology that have large bulky inclusions, unlike tufted astrocytes of PSP. You can also see both the globular and the astrocytic, and as well the thread-like inclusions in the gray matter of this entity. So anyway, I offer you this as an opportunity to study up on the neuropathology of globular glial tauopathy and add that to your collection of available images. And with that, I will turn it back to our hosts.
Yes.
To
thank you so much.
get the
At
Q&A
this time,
session.
we're going to move into Q&A. You can submit your questions via the chat box, or you can unmute to ask a question. When submitting a question via the chat box, please ensure the message is to everyone so that the presenters and attendees are able to see the question. To unmute, select the microphone in the lower left corner, and once you've asked your question, please remute to avoid background noise. All right, so you have a bunch of thank yous, and I do already see a question from Mark Cohen. It says, fantastic talk, Chuck. I have a hard time thinking of PSP as a form of FTLD. Do you know the rationale for including PSP as a type of FTLD?
I think that's a great question, Mark. And obviously, from a number of standpoints, one can classify these tauopathies in a variety of different ways. And certainly, we think of PSP as most commonly a Parkinsonian disorder. But I think the thing that got me to thinking about PSP as a cognitive disorder was in presenting some CPCs at our Alzheimer's Center and people who had not come through the movement disorder clinic, but had come through the ADRC and were thought to have dementia with Lewy bodies because they had Parkinsonism and cognitive impairment. And we identified that several of those subjects actually had underlying PSP. And I think that's been sort of the experience of a number of others as well, that you can have an FTD-like presentation. But I agree with you. I think it's a little bit of just a consensus, but it can certainly be argued that it's mostly a Parkinsonian disorder and not exclusively an FTD by any stretch. Okay. I think the same could be said for CBD. Okay. Mostly Parkinsonian.
And so next we have Hector Lara. I have two, he says, thank you. And then he says, I have two questions. Number one, I find it hard to distinguish an astrocytic plaque and a neuritic plaque. How can I differentiate them?
Okay, I think that's a great question. I think there are two ways to do that. One of which is to do a thioflavin stain. Neuritic plaques should be positive with thioflavin, and both the neuritic component and the amyloid component should be negative in an astrocytic plaque of CBD. The other thing would be to do side-by-side 3R and 4R taus. They should be exclusively 4R positive. And then, I think the other thing that often tips me off to a diagnosis of CBD as opposed to AD is the presence of substantial white matter pathology and the presence of these balloon neurons, which again can be seen on H&E, but also demonstrated to advantage with alpha B crystal immunohistochemistry. Of course, that completely side skirts the issue of what if you have somebody with concomitant or comorbid AD and CBD? That gets a little bit more dicey, but CBDs, I would say, are most often in people who are a little bit younger than the usual spectrum for AD and C, so that's another helpful sign. But I agree, it's not always easy to differentiate them, especially just with an ATA.
Okay, and then I'm not sure if you answered this, but his other question was, how do you differentiate an early PSP in a brain with intense AD and C?
Very difficult. I think the presence of 4R immunoreactive tufted astrocytes is helpful, and also, Alzheimer's disease doesn't typically involve the substantia nigra and the globus pallidus and the subthalamic nucleus with neurofibrillary tangles the way that PSP does. So I think doing immunohistochemistry for 4R tau lesions or even just phospho-tau lesions in those subcortical areas is pivotal in identifying PSP.
And then Charles Rhodes. At a time, there was some discussion that CBD and PSP might be two manifestations of a single disease, with many cases with an intermediate presentation. What is the current thinking?
There are certainly cases that are difficult to discriminate between CBD and PSP, and I think that the consensus right now is to call those cases 4R tauopathy with features of PSP and CBD, and to recognize that sometimes it's impossible to discriminate between those two conditions.
Okay. And then I'm really sorry, there was a request for Charles Rhodes should have been introduced as Harker Rhodes. Sorry. And then next I have Muhammad Harry, great talk. And then it just says, what do you think about incidental PSP?
Incidental PSP. Tom Beach has a large number of cases that he has identified in his centenarian population from Sun City. And I think that he has demonstrated that it can be asymptomatic, and it's a fairly ubiquitous, no pun intended, entity that is seen in a substantial number of older people. It may be, like another Brock stage 1 or 2 ADNC or part in that respect, an age-associated phenomenon that isn't always symptomatic. So I think it truly exists at a neuropathologic level.
Okay. And then Mark Cohen asks, do you think Dr. Strangelove had CBD?
Good question.
You don't have to answer those questions if you don't want to. And then
Mark, you're getting into movie references that about 80% of this audience are not going to recognize because they're not as old as we are.
Okay.
Always thin ice.
Yeah. And then I have another question. Jeffrey Hoffman, in a classic late stage ADNC case, would you expect to see essentially zero p-tau aggregation in glial cells, i.e., is it all in neurons?
You can see glial cells in ADNC that contain tau. Interestingly, it's typically astrocytes. The phenomenon of tau aggregating in astrocytes is an interesting one because there have been some studies that show that tau expression is not upregulated in those astrocytes, and it's thought that astrocytes tend to ingest tau from the neuropill, tau that's made by neurons. Curiously, it also seems that astrocytes are selectively able to ingest only 4R isoforms of tau. Anyway, so that's an interesting pathophysiologic phenomenon, but I think you can see some astrocytic accumulation of tau in advanced stages of ADNC.
And then I actually have a question for you. So, I teach a lot of year 2, and obviously you cannot teach every detail, like you said, we'd be here a very long time. And so sometimes I teach, that the beta amyloid plaques are kind of like tombstones, and, to explain what happened with all the research, the treatments. And, if you remove a tombstone, the person underneath is not going to get up and walk out. And just kind of as an outside observer, because obviously I'm not a dementia person. It seems like a lot of the research talks and stuff I hear now are tau. It's all tau now. So how do we know we're not making the same mistake with tau? That the plaques, they all obviously have some role or some marker, or they're telling us something. But how do we know that we're not making the same mistake as putting in this extraordinary importance to tau, the way we did it with the beta amyloid, that may not give us treatments?
I think that's a good question. I think that all of the therapies that are designed to remove deposits that have been present for maybe 20 years after somebody's lost all their synapses, it's not going to do anybody any good. And I like the analogy that giving somebody in congestive heart failure from a long-standing ischemic heart disease, treating them with statins and expecting them to get better on that basis is unlikely. But I think the one aspect of attacking tau is the fact that we think that tau is the molecule that's linked to the neurodegeneration component of Alzheimer's disease pathology. And so maybe it's more proximate to the actual underlying cause of clinical disability, whereas the things that are directed at removing amyloid are supposed to be removing the toxic moiety that results in tau deposition. But again, you're not going to reverse tau deposition by reversing amyloid after the tau's been there for a long time. So I guess the
So you got to start
possibility.
taking these medications 20 years before you get your Alzheimer's.
That's, yeah, early detection is the whole thing there, other than putting
Okay.
everybody in the population on anti-amyloid drugs and anti-tau
Yeah.
drugs.
So there actually are a bunch of questions more that have popped up. I think we still have a couple more minutes. And Howard Chang says, comments on primary age-related glial tauopathy, question mark. Not sure what the question is.
I'm not sure I understand that question.
I don't either. It just says, do you have comments on primary age-related glial tauopathy?
Oh, okay, good. RTAG. Yes, I did not put RTAG in here. Again, I had to just like pick from the universe of tauopathies to decide what to discuss. RTAG is clearly a very commonly observed phenomenon. There are some early papers now suggesting that there may be some clinical associations, but it's not a very tight association yet with specific clinical disability. And so I decided not to discuss it, but I would certainly refer you to articles by Gabor Kovac et al. on RTAG, at least in terms of current concepts on how we think about it and classify it.
And then I think this might be the last question. What are future directions in the classification and diagnosis of tauopathies?
Well, I think there are two things that I would think are going to be important, one of which is the use of artificial intelligence and machine learning to discriminate lesions based on their morphology. And there's already been some work in that realm discriminating between PSP and Alzheimer and CBD tauopathy. And I think the other is this evolving field of cryo-electron microscopy. I mean, I can't right now envision how that would be easily translated into the clinical arena for rapid turnaround and high throughput use, but certainly I think that it's telling us some more about the uniqueness of many of these diseases, and it may have something to do with how they transmit or progress through brain parenchyma. Different diseases we know have different patterns of involvement, and the thinking is that there's this proteopathic templating and prionic spread of aberrant tau molecules throughout the brain, but different diseases have different patterns of involvement at the gross level. And maybe cryo-electron microscopy is going to help us understand those patterns of spread and the translation of aberrant tau from one cell to another.
Cool. Okay, well, there are a whole bunch of thank yous, which I did not say out loud. And I guess that's it. Thank you very much. This is awesome. And I guess I could say goodbye to everybody.
My pleasure. Yes. Thank you, everyone.
Thank you, Dr. White. Just a few closing announcements. Thank you again for joining today's AANP Teaching Rounds presentation. We would ask that you take a few minutes to complete a short evaluation. Completion helps ensure accurate reporting to the accreditation board. A link to the evaluation will appear on your PATH LMS screen upon conclusion of the Zoom meeting, or you can navigate back to the main course and select the evaluation option. Once you've completed the evaluation and selected your credit amount, then please select the appropriate certificate based on your credentials. The PowerPoint slides and recording will be posted to the AANP website in the next week. And thank you once again to Dr. White for an excellent presentation. This concludes the session for today. Thank you, everyone.